Congenital head anomalies, hydrocephalus and Arnold-Chiari malformation. This lecture is presented by Dr. Mohammed Al-Tamimi, a consultant neurosurgeon and an assistant professor. The hydrocephalus word is derived from the Greek words water in the head. As the name implies, it refers to a general condition whereby there is an excess of the cerebrospinal fluid within the intracranial space, specifically the interventricular spaces within the brain. This will lead to the dilatation of those ventricles and a wide range of symptoms. We will pass through some important facts and physiology. The majority of the CSF is produced by the choroidal plexus within the brain. This process happens through a metabolically active one. It requires ATP, whereby the sodium will be pumped into the subarachnoid space and the water will follow from the blood vessels. The choroidal plexus is primarily located within the lateral ventricle. However, some of them are located in the posterior third ventricular roof or the caudal fourth ventricular roof. The average adult brain produces about 450 cc's up to 600 cc's of the CSF every day. But normally the production should equal the absorption. At any given moment, there is only 150 cc's of the CSF distributed within the brain. Of this, only 25 cc's within the brain ventricles. So the CSF volume turns over 3 to 4 times every day, with only a very small fraction of the CSF being in the ventricles at any given time, even though the majority of it is produced there. The CSF production and resorption system exists in a delicate balance under normal conditions. In the CSF pathway, the CSF starts to flow from the two lateral ventricles through the foramen of the mono into the third ventricle. That's located in the midline. Then it passes through the cerebral aqueduct of Sylvius into the fourth ventricle. It then exits the fourth ventricle through either the two lateral foramens of Luschia or the central one of the Magendie. After exiting the fourth ventricle, the CSF will flow through the subarachnoid space, over and around the brain and the spinal cord, and is eventually reabsorbed into the venous blood system through the numerous arachnoid villi distributed over the venous sinuses. The arachnoid granulation contain those arachnoid villi, which functions as a pressure-dependent one-way valve that opens when the ICP is about 3 to 5 cm H2 or greater than the dural venous sinus's pressure. What to remember is that the CSF cell production is a metabolically active process, while the CSF reabsorption is a passive process that is driven by the pressure gradient between the intracranial pressure and the venous system pressure. When there is an imbalance between the CSF production and absorption, hydrocephalus will exist. So the hydrocephalus is defined as an increment in the CSF volume. You remember that the normal CSF volume is about 100 to 150 cc's. 50 of them is located within the ventricles, 25 cc's around the brain, 75 cc's around the spinal cord. You may also remember that the CSF production should remain constant at about 35 cc's, which equals 500 to 750 cc's per day. The mechanism that lies behind the existence of the hydrocephalus is either an increment in the production or a decrement in the absorption. Hydrocephalus can be classified into either an obstructive one, named non-communicating. Here the absorption is being blocked within the ventricular systems, so no more CSF will escape into the subarachnoid space. There are a lot of causes for that obstruction, either an intraventricular hemorrhage or ventricular tumors, or some masses from outside the ventricle that may obstruct the outlets, just like infratentorial masses that obstructs the aqueduct, supratentorial masses that obstructs the aqueduct or through the tentorial herniation. In the CT findings, you may see that the lateral and the third ventricles being dilated, whereas the fourth ventricle remains normal in volume. The other type is named communicating or non-obstructive one. Here, the absorption is blocked at some part of the extraventricular pathway, such as the arachnoid granulation. The causes behind that could be either trauma that leads to the subarachnoid hemorrhage or a meningitis. In the CT findings, the difference from the obstructive one is that all the ventricles are being dilated. There is an entity named normal pressure hydrocephalus. This is a one type of the communicating hydrocephalus. The patient will present with a gradual onset of the classical triads: gait apraxia, incontinence, dementia. The CSF pressure often remains normal in range. Hydrocephalus ex cavu is not a true hydrocephalus, but an enlargement of the ventricles secondarily to the diffuse brain atrophy. Usually this is a normal function of the normal aging. The patients with hydrocephalus can either present with an acute signs and symptoms or a chronic one. The acute signs and symptoms are those of the acute raised intracranial pressure. Usually they happen with the non-communicating type. With the chronic hydrocephalus, the presenting signs and the symptoms are similar to those of the normal pressure hydrocephalus. In order to assess the patient with the hydrocephalus, you have to do a computerized tomogram. Here, the ventricular enlargement may be seen, and the most prominent ones are the temporal one. Periventricular lucencies may exist. Narrow or absent sulci or fourth ventricular enlargement may exist. Ultrasound through anterior fontanelle in the infants may show the ventricular enlargement. In the management, the spinal taps, usually for transient communicating one. You may remove obstruction if possible. You may do a choroidal plexectomy or a third ventricular stomy for the obstructive type. For the cases where there is no pathology to be cleared, the shunts may be an option as a treatment. Ventricular peritoneal shunts from the ventricles to the peritoneum, or ventriculoarterial shunt from the ventricles to the atrium, or the lumboperitoneal from the lumbar spine to the peritoneum, especially for the communicating type. This illustration shows the upper end of the catheter inserted into the ventricular system connected into the device, and from there will be a tunneling subcutaneously of the lower end towards its trajectory within the peritoneum. Arnold-Chiari malformation. There are 4 distinct types of Arnold-Chiari malformations, and they are not related to each other. Arnold-Chiari malformation type 1. The age of the presentation is usually within the adults with the slight female predominance. In the features, it's a heterogeneity entity, but the common feature is an impaired CSF circulation through the foramen of the magnum. There will be a caudal displacement of the cerebellum with tonsillar herniation below the foramen of magnum. More than 5 mm below the foramen of magnum, not essential and not diagnostic. In order to assess a patient having a hydrocephalus, you have to send him for certain investigations. One of those is a computerized tomogram. In the computerized tomogram, you may see the ventricular enlargement with a prominent temporal horns and some periventricular lucencies. The lucencies happens due to the CSF being forced extracellularly. You may see also a narrow or absent sulci, plus minus fourth ventricular enlargement. For the infants with still open fontanelles, you may send the patients for an ultrasound. Here you may find also a ventricular enlargement. In managing a patient with a hydrocephalus, you have first of all to treat the cause. So if the patient is presented with an obstructive one due to an existing tumor, you have to remove that obstruction through removal of the tumor itself. Sometimes for the patients with obstructive hydrocephalus, a third ventriculostomy may be applied. A spinal tap for the communicating hydrocephalus gives only a transient relief. Choroidal plexectomy is one of the choices of the treatments for the patients having a choroidal plexus papilloma. For patients with communicating hydrocephalus, you may refer the patients to do a shunt surgery. There are a lot of ways to do the shunt surgery. The shunt is a device that overcrosses the obstruction. We have got a ventricular peritoneal from the ventricles into the peritoneum, or ventricular arterial from the ventricles into the right atrium, or lumboperitoneal from the lumbar spine into the peritoneum. In this illustration, you can see that there is a catheter being inserted into the lateral ventricle in the head. This will overcross the obstruction, being connected to the small valve device that opens according to the pressure gradient, and then connected into the lower end, and the lower end will be tunneled under the skin towards its trajectory into the peritoneum. Arnold-Chiari malformation. There are 4 distinct types of Arnold-Chiari malformations, and those subtypes are not correlated with each other. Arnold-Chiari type 1. Usually the age of a presentation is an adult with a slight female predominance. The features here are heterogeneous, but the common feature is an impaired CSF circulation through the foramen magnum, with a caudal displacement of the cerebellum with tonsillar herniation below the foramen magnum. The patients may have an coexisting syringomyelia or a hydrocephalus. There are different etiologies can be with it, just like small posterior fossa, like intracranial space occupying lesions, arachnoid web or scar or fibrosis around the brainstem and the tonsils, especially in the area of the foramen magnum. This picture shows Arnold-Chiari malformation type 1, where there is a cerebellar tonsils extending through the foramen magnum. This is an MRI view, shows the cerebellar tonsil being herniated through the foramen magnum. The etiology of the symptoms can range according to the pressure effects. So a compression of the brainstem, hydrocephalus, and a syringomyelia can lead to a wide variety of symptoms, ranging from weakness, numbness, loss of the pain temperature, unsteadiness, diplopia, dysphagia, tinnitus, vomiting, and dysarthria. The etiology of the signs may be related to the foramen magnum compression. This will lead to ataxia or central cord syndrome, loss of the pain and temperature sensation, segmental weakness, syringomyelic syndrome, or lower cranial nerve palsies. The signs may be also related to the cerebellar symptoms, where the patient will present with ataxia, nystagmus, or dysarthria. MRI is the diagnostic image of test, and the abnormalities that can be seen here is the tonsillar herniation, hydrosyringomyelia, ventral brainstem compression, or hydrocephalus, or empty cella. The other imaging, just like the MRI, CSF flow study, or myelogram or CT may be applied. The treatment is surgical, especially for the symptomatic patients. You have to decompress the brainstem and re-establish the normal CSF flow at the craniocervical junction. This can be applied through posterior fossa decompression. We named it suboccipital craniotomy, all together with a dural patch and laminectomy of the cervical vertebrae 1 and 2 and maybe 3 with it. Arnold-Chiari type 2, the onset of the symptoms in the adulthood is rare. The features are a caudal displacement of the craniomedullary junction, all together with the pons, the fourth ventricle, the medulla, cerebellar tonsils will be located at or below the foramen magnum. Usually Arnold-Chiari type 2 is associated with a myelomeningocele and is often accompanied by hydrocephalus. In the pathophysiology, the primary dysgenesis of the brainstem with multiple other developmental anomalies may coexist, and those are not the result of the tethering of the associated myelomeningocele. The etiology of the symptoms are brainstem and lower cranial nerves dysfunction, So the patients may present with dysphagia, dysarthria, apnea, stridor, aspiration, arm weakness, opisthotonus, nystagmus, facial weakness, weak or absent to cry. Again, MRI is the imaging of choice. Here you may see elongation, or we name it cervicalization of the medulla, low attachment of the tentorium. In the associated findings, you may find hydrocephalus, syringomyelia at the cervicomedullary junction, trapped fourth ventricle, cerebellomedullary decompression, agenesis of the corpus callosum. The treatment of choice is that you insert a CSF shunt for the hydrocephalus, and the surgical decompression is recommended only for a neurological deficit in the lower cranial nerves. Arnold-Chiari type 3. Here there is a displacement of the posterior fossa structures with the cerebellum herniated through the foramen of magnum into the cervical canal. There will be a coexistent high cervical or suboccipital encephalomenincocele. Usually this is incompatible with life. Arnold-Chiari type 4. Here there is a cerebellar hypoplasia without cerebellar herniation. Thank you.